Welcome to this comprehensive guide on the respiratory examination. Welcome back to the Asthma Cures channel. In this video, we will cover the key steps involved in performing a detailed respiratory exam, including inspection, palpation, percussion, and auscultation. The respiratory system is essential for oxygenating tissues. Any abnormalities in the respiratory system can indicate serious disease. The respiratory examination is a systematic approach to identifying these abnormalities and forming a clinical diagnosis. A methodical approach ensures that key findings aren't overlooked. Follow this process. First, history. Always start by taking a thorough history to understand the symptoms. Second, inspection. Assess the patient's general appearance and look for signs of respiratory distress. Third, palpation. Examine the chest for any signs of asymmetry or abnormal vibrations. Fourth, percussion. Tap on the chest to detect areas of dullness or hyperresonance. And finally, auscultation. Listen for breath sounds to detect abnormalities like wheezing or crackles. By following these steps, you'll be able to form an accurate diagnosis. Inspection helps identify early signs of respiratory distress. General appearance. Observe for signs of dyspnea, such as rapid breathing, cyanosis, or use of accessory muscles. Posture. Patients may adopt a tripod position, leaning forward in respiratory distress. Cyanosis. Check for bluish discoloration of the lips, face, or extremities, indicating oxygen deficiency. Clubbing, often seen in chronic diseases like COPD or interstitial lung disease. Chest shape. A barrel chest suggests emphysema. Palpation helps assess chest symmetry and lung function. First, check the tracheal position for any deviation. A deviated trachea can indicate pneumothorax or massive pleural effusion. Next, evaluate chest expansion. Reduced expansion may suggest pleural effusion or pneumothorax. Then assess tactile phremitis. Ask the patient to say 99 while palpating the chest. Increased phremitis suggests pneumonia, while decreased phremitis can point to pleural effusion. Percussion helps identify air or fluid in the chest. Normal resonance is expected over healthy lung tissue. Dullness, on the other hand, indicates consolidation, such as pneumonia or fluid, like pleural effusion. Hyperresonance points to air trapping, which is seen in conditions like pneumothorax or emphysema. Auscultation is crucial for detecting abnormal breath sounds. Normal breath sounds are vesicular and heard over most lung fields. Bronchial breath sounds should only be heard over the trachea. If heard in the lung periphery, it suggests consolidation. Wheezes, which are musical sounds, suggest bronchospasm, seen in asthma or COPD. Crackles, whether fine or coarse, suggest fluid in the alveoli, such as in pulmonary edema or pneumonia. Lastly, a pleural rub, which is a dry rubbing sound, is heard in pleuritis or inflammation of the pleura. Let's look at some clinical cases. Case 1, pneumonia. History: a 55-year-old man with fever, productive cough, and pleuritic chest pain. Examination: increased tactile phremitis, dull percussion, and bronchial breath sounds. Diagnosis: right lower lobe pneumonia. Case 2, COPD. History: a 68-year-old smoker with chronic cough and increasing dyspnea. Examination: barrel chest, hyperresonance, and diminished breath sounds. Diagnosis: COPD. Case 3, pleural effusion. History: a 40-year-old woman with breast cancer and progressive breathlessness. Examination: reduced expansion, stony dull percussion, and absent breath sounds. Diagnosis: left-sided pleural effusion, likely malignant. Case 4, pneumothorax. History: a young man with sudden chest pain and breathlessness. Examination: tracheal deviation, hyperresonance, and absent breath sounds. Diagnosis: spontaneous pneumothorax. Case 5, pulmonary fibrosis. History: a 62-year-old man with exertional dyspnea and a history of asbestos exposure. Examination: clubbing, fine crackles, and reduced chest expansion. Diagnosis: pulmonary fibrosis. When presenting your findings, clarity and conciseness are key. Here's an example. On general inspection, The patient appeared breathless and cyanotic. The trachea was midline and chest expansion was reduced on the right. Percussion revealed dullness on the right lower side, and auscultation showed bronchial breath sounds and fine crackles. These findings suggest a diagnosis of right lower lobe pneumonia. Red flags include tracheal deviation, which indicates tension pneumothorax or a massive pleural effusion. Absent breath sounds coupled with hyperresonance suggest a pneumothorax. Sudden dyspnea along with leg swelling could indicate a pulmonary embolism. If you encounter these signs, take immediate action to stabilize the patient. Let's go through some common Viva questions. First, key questions on inspection. What does central cyanosis indicate? It indicates hypoxemia, which is seen in conditions like COPD or a pulmonary embolism. What does a barrel chest suggest? It suggests emphysema. Palpation and percussion questions. What does increased tactile fremitus indicate? Increased tactile fremitus indicates pneumonia. What is the significance of hyperresonance? Hyperresonance indicates air trapping, seen in pneumothorax or emphysema. Auscultation questions. What do bronchial breath sounds indicate? Consolidation. Differential diagnosis questions. How would you differentiate pneumonia from pleural effusion? Pneumonia shows increased fremitus and bronchial breath sounds, while pleural effusion shows decreased fremitus and absent breath sounds. A systematic respiratory examination is key to identifying underlying diseases and forming a diagnosis. By following this approach, from inspection to auscultation, you'll be able to make confident clinical decisions. Thank you for joining this detailed walkthrough of the respiratory examination. With practice, you'll develop the expertise to confidently assess and manage respiratory conditions. Stay curious and keep listening.